responsibilities is to monitor and evaluate the success of our practice transformation program. So you'll have an opportunity to give us some feedback on that today, and then just to suggest improvements to the program or areas that you think are lacking. Since you are all stipended very generously to attend this meeting, what I would ask for everybody to do is to self-introduce. We'll go around our room first. We're at the United Way facility here, and we have lots of people in the room, so I'll ask people to self-identify so that we can capture who's here, and then we'll go to the phone for that. So we'll start with Bill Dunwoody.
Bill Dunwoody with
Liz Rice, Tri-State Health. Good morning, Harvey, Ms. Lord.
West Lucky, Greater Columbia. So very loud.
Sierra Foster with Austria Health. Shanna Shelton, Greater Columbia ACH.
Carol Moser, Greater Columbia ACH.
Martin Sanchez, Greater Columbia ACH.
Becky Cole, Greater Columbia ACH.
Lauren Noble, Greater Columbia ACH. Becky Gross. Sophie Chapman, Greater Columbia ACH.
Could you help me figure out who's on the phone? I think. So Amelia, do you want to introduce yourself?
Hi, this is Amelia Davis with Coordinated Care.
Thank you, Amelia. Brian Sandoval.
Brian Sandoval, Clinical Director, Primary Care Behavioral Health, Yakima Valley Farm Workers Clinic.
We have Dan Ferguson.
Yeah, this is Dan Ferguson with the Allied Health Center of Excellence with the community college system, and I'm hosted at Yakima Valley College.
Thank you, Dan. And Ed?
Hi, this is Ed Thornbrew with Comprehensive Healthcare.
Thank you, Ed, for joining us. Kat?
Good morning, everybody. Kat Latte from Community Health Plan of Washington.
Thank you, Kat. Paul?
Good morning, everybody. This is Paul Cashmetter from Community Health of Central Washington in Yakima.
Are you going to be our replacement for Dr. Maples, Paul?
Right now I'm standing in for Angela Gonzalez, our new CEO.
Okay. Thank you very much for joining us this morning. Welcome. Rick George?
Yeah, Rick George, Comprehensive Healthcare.
Hi, Rick. Good morning. Thank you for joining us. Ms. Wardell, you're on the line.
Sam Wardell, Greater Columbia.
Sam is unfortunately suffering from bronchitis and strep throat, so we are making her stay home today. And then there's three other callers. There are three other callers that are not identified. Would you please go ahead and tell us who you are? I always have these workers. We have caller 1, caller 2, and caller 3. Do you have an association with those? Okay. I'm always so curious to know, who are those callers that don't want to identify themselves? Okay, so as you know, you'll be stipended at the end of the year for the meetings that you've attended. Each meeting is worth around $1,250. So for those of you that are calling in today, we really greatly appreciate your attendance. Mark and Brian, Mark Wakai, you had RSVP'd. Are you on the line? I guess not. So, Brian, did you want to make any welcome or introductory comments for the group since you're one of the co-chairs?
Yeah, I don't really have much. Really interested to see kind of where we're at. I think that'll help us kind of move and see what the next steps are moving forward. But yeah, welcome everybody, and yeah, glad to be here.
Thank you. We have the minutes from the July 25th meeting that were sent out. Did anybody have any corrections, additions to the minutes? If not, could I entertain a motion to approve the minutes as presented? Barbara? Yes. Barbara is approving the minutes as presented. Do I have a second? Bill is the second. All those in favor of approving the minutes as presented, say aye.
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 Are there any opposed? Okay, so the minutes are approved. I'm now going to hand the microphone over to Martine and Jenna, who are going to take us through some overview comments of the overall process, and then we'll launch right into the updates for Cohort 1 and Cohort 2 third quarter.
Ready?
Cohort 1.
So this is what you guys are seeing is the dashboard that we manually create that will hopefully in the near future will be all electronic and not so manual, which would be good. But you guys have seen this in the past. At the bottom of this Excel sheet, you guys will see quarter 1, quarter 2, and quarter 3. And those are the progress that has been made throughout the quarters. You know, you guys will see the yellow, green, and red, meaning that, you know, yellow, they're planning on implementing. Green, they have implemented, and red, they have not implemented. One thing that we'll notice in this dashboard for quarter 3 is that there was some color changes that went from green to, or from yellow to green, and then some jumped back from green to yellow. And then I'll give a little explanation as to why that happened. And then one thing that you don't see here, other than on the top row, is any red in the cells down below. So that means at least everybody is planning on implementing, have implemented it in some fashion or manner, but not to its full capacity. And then the green, you guys will see that, you know, they have implemented that specific piece into their practice. And this dashboard goes over the 4 project areas that we have as an ACH, which are bidirectional integration, transitional care, opioid crisis, and chronic disease and prevention. On the top, for each row with the 4 project areas, you guys will see in parentheses to which milestone we extract this data from, what we look at in the workbook. Bidirectional integration is 2B1, which, if you guys have seen the workbook, focuses on the 3 types of integration for primary care or any other type of integration for the other sites that are not primary care. Yes, the worksheet will be sent out. That was a comment that came across and I just read. It will be sent out after this meeting, so you guys can take a look at it as well. And then I'll do, we'll go over the first one. We'll focus on bidirectional integration. On here, one thing that you guys will notice is everybody's green, which means there's some type of integration in all of the sites for cohort 1. And you guys will see on there, you know, there's the AIMS, the BREE Collaborative, and co-location. Some of the sites have a combination of either 2 or a combination of all 3 of the models of integration, and that's because they, you know, that's how they have implemented this process into their practice. And you guys will see on there, if you scroll down a little bit, Chelsea, that, you know, Astria, Yakima, all of the sites really, you know, are integrated and are on the green for this project area for Greater Columbia, which is great. We have seen all of the benefits that the patients are receiving, you know, not only the patients, but also the providers that are taking care of these patients. For the co-location piece for the bidirectional integration, we're still getting confirmation, but for the most part, co-location, everybody has a shared care plan that they are using, meaning that behavioral health and primary care have access to the same care plan and are able to input their notes into that instead of having two different care plans and not knowing what one is doing from the other provider. And this just gives them a better sense as to how to approach the patient and how to treat them and give them the best treatment possible. If you scroll up, Chelsea. The next area for all of the sites is, I believe it was transitional care. Can you scroll up a little more? Yep, transitional care. For this area, there's some organizations that jumped from green back to yellow, but that does not mean that they're not implementing, transitional care, which is follow-up after inpatient hospitalization or follow-up after a patient goes to the ED. This just means that they were missing some data points. They failed to provide some data in the workbook, but that doesn't mean that they're not accomplishing, making sure that they're following up with the patients. They might have just forgot to input the data, but that's why they're in the yellow. And one thing that Jenna and myself are doing with these sites that have some yellows in them is where we are following up with them to make sure that they get the money that they deserve because they're doing the work, and making sure that we're following up and that they have implemented these processes. So it's not just, oh, they're not doing it, don't worry about it. We do follow up with them and ask questions like, hey, what's your impoundment? Why does it look like this? Or why don't you have any data for shared decision making? Things like that. So, and Carol's laughing probably because all these milestones that Jenna and I have memorized by heart now. When we saw this at our last kickoff meeting, we just went over the workbook just off the top of our heads, which is cool to know that we have that down already. So that's what the yellow means. And again, it doesn't mean that they're not doing it. It just means that there's some missing some information or some parts, but they are working on areas. On here, we see transitional care. For the most part, everybody is in the green. Keep going down. So it's just a clarification. And on here, you guys will see some notes as well, and I read that far away. So this one's green. They're needing access to EDI, but they are still doing the follow-up after inpatient hospitalization or after a patient uses the ED. They're just getting their information a different way other than the collective medical platform.
Can you explain what we're doing to try to get access to EDI for our providers?
Yes. And you guys will see more yellow in this section for our cohort 2 sites. And that's because we are working with the MCOs in our region, the 4 MCOs that are in our region, to get sponsorship to these organizations, meaning that the MCO will pay the fee to get EDI or collective medical into the organizations. And once a site has access to collective medical, all the other sites that are affiliated with that organization get access to collective medical as well. So it's not just one site, it's the whole organization that gets access to this site. We have developed a workflow with the MCOs. We had a phone call where, in the past we were going back and forth, hey, who's willing to sponsor these organizations? It's just kind of back and forth until we decided, okay, what's the proper way to get organizations into a more systemized form of getting organizations into collective medical. So we had a phone call where we developed a workflow with the voice of the MCOs as to how we were going to be given access to collective medical, which is we send out an email with all the organizations that we are working with and the sites, and send that out to the MCOs and basically just ask them, hey, who's willing to sponsor who? And basically they just pick who is going to be sponsoring. They send that information back to us, and then what we do on our end for the ACH is Jenna and I contact our sites and tell them, hey, this is the MCO that's going to be sponsoring you. Look out for an email from this person. They'll be sending you some forms that you'll need to fill out, which is a discovery form and a patient file form. As a way, and those serve to identify, to who the patients are associated with, as to what organization, what clinic sites, and who their provider is. That way, when they're in the hospital or in the emergency department, their provider gets a notification, hey, your patient is at the hospital for this reason. And that plays into this milestone 6, which is care coordination across the medical neighborhood, to have that follow-up done with those patients that are flagged in their system as being in the hospital. So that's how we're working with the MCOs to get access to this to collect the medical platform, which is EDI and pre-manage. And for cohort 1, as you guys will see, we have done some good work in getting access to some other organizations. In the past quarters, there was a lot of yellow in this area, but now for the most part, everybody is green for cohort 1. Once we jump onto cohort 2, you guys will see there's some more yellow on there. And everybody has that's on the green has been doing a good job at making sure that they are following up with those patients that are in the hospital. And then the next one is the opioid crisis. And this one includes, just specifically looks at the medication management piece of milestone 2, which is milestone 2B.3.A, which is the last milestone or the last section in milestone 2. And this one is basically asking the sites, how are you accomplishing medication management for your patients? What resources do you have available to get that accomplished? Do you have access to the PDMP, the Prescription Drug Monitoring Program? Do providers do med reconciliations with your patients when they're in the office? What guidelines are you guys using? If you guys do prescribe, what guidelines you guys are using? We want to make sure that they are basing their decisions on something that's evidence-based and not just, hey, let me write this off. So we want to make sure that everybody's compliant in that piece. So if you guys are familiar with the workbook, there's a whole bunch of options on here that you guys can select from as to how, some organizations are accomplishing medication management. This piece also adds for if a clinical pharmacist is part of the care team and how that pharmacist is engaged in patient care, how they are part of the care team for the patient, and what duties do they have with that patient, and how many hours are they involved in patient care for the organization. And some organizations don't have a clinical pharmacist on site because we know they're expensive, and some of the organizations that we're working with are small, that they're not able to provide that service to their patients. But some are using telemedicine, which is kind of like telehealth, a pharmacist over the phone that's able to, provide services to the patients that need, their medications, more education on their medications. Which Estrella Sunnyside, which is here, they are using that service. So that's why I bring it up. And, when we're out in the site, we always, hey, there's these other services like telepharmacy that you guys can be using with the funds, that we are providing through this work that you guys are doing. But, for the most part in this section, I believe everybody's on the green, which is great. If you scroll down, Chelsea. Yep, so everybody from all the organizations. So there's, in one way or another, all the sites that we are working with are looking into the medications that the patients are taking and that they are being prescribed. So that is awesome. The next section would be chronic disease and prevention. There are some organizations on here that are in the yellow, and that's because there's some data points missing, for questions that we look at for these specific question. And on the top, you guys will see that we look into milestones 2A3, which is self-management. 2B2, actually no, 2A3 is
Additional opportunities.
additional opportunities for those at highest risk. 2B2 is the self-management, and 5A2 are the clinical quality metrics that organizations are supposed to be looking into for every quarter that were chosen in Q1 and can be changed throughout the quarter. So they have been focusing on these clinical quality metrics for 5A2 throughout the last 3 quarters, going into their 4th quarter this time around. And again, we can see that if scrolling down, for the most part, everybody is on the green, but then again, the yellow is that they're missing some data on their workbooks, and that's why they're in the yellow. But we're working on with these sites to get that data and get them.
I have a quick question,
Yes.
if that's okay.
Yes.
Just looking at the ones that are in yellow, they're all hospitals. Does that have anything to do with why there might be missing information there?
That
Not sure.
Repeat the question, please.
Yeah, so Sierra asked, the organizations that are in yellow for the most part are hospitals, and why is that? Why they're in the yellow? That can be from the tracking perspective that no numbers were provided. That doesn't mean that you guys aren't providing services. It's just a matter of, hey, we gave out a decision aid on this. Did we track it? Yes or no?
Mm-hmm.
And it's providing those numbers, because that kind of tells us, Jenna and I know that you guys are doing it, but Sam ultimately has the last word. So when she doesn't see numbers, it's like, hey, what are they doing? Are they actually implementing this, or are they not? So that's that's why that piece. But what I can tell you guys is, from my perspective with the organizations that I'm working with, everybody has accomplished a lot through their first 3 quarters. If you guys here on the barriers piece, there's a lot less barriers this quarter than the past quarters. The workforce issue was a little bit less. The organizations were successful in hiring for the positions that they were looking for. So there are some barriers, of course. The first one is EHR transitions. We have organizations that did transition during Q2 to Q3. They transition into a whole new EHR. So there's that learning piece that comes with it, transferring data into it, getting the reporting how they want it to look, making sure that they're tracking the things that they need to track. So there's that learning curve, when transitioning into new EHRs. And change is always difficult when you're used to, having the same process, same software, bringing in a whole new tool that you're not familiar with. There can be some pushback, but ultimately you have it, you kind of have to use it. But that can be that was one of the barriers for Q3 for cohort 1. There was some staff turnover that included leadership, and we know that leadership is really important to drive this work. They're the decision makers that drive down the work to the people that are actually doing it, and having leadership step out, basically in the middle of this project, having that knowledge of all the work that has gone into this work, and having somebody new, and it's like, whoa, it's a lot to learn and to catch up on. But I feel that Jenna and I do a pretty good job at kind of catching up people as to, the things that have been going on, who we work with, kind of explain how this work came to be and why we're doing it. There's, again, 42 CFR compliance. This is a big one since we are working with behavioral health organizations in cohort 1. We know that 42 CFR is a big barrier for sharing information for these patients with substance use disorder. That we're hopefully going to be tackling with the piece on collective medical. They have a piece. They're able to work around 42 CFR when pre-managed is implemented or collective medical is implemented in their organization. So for this barrier, we're hoping to hopefully work around it, not eliminate it, but have a work around this issue that, providers are seeing. The next one is opportunity to enhance billing workflows that will offer sustainability. Through this work, we have asked you guys to implement new things, hire new staff, do a whole bunch of things, right? But, right now you guys are getting funding from us that is keeping that sustainability alive. But after, this work is done, this project is done, we still want you guys to be sustainable in the things that you guys have implemented. We don't want them to just be here for 3 years and after our funding, hey, we don't have that funding no more, let's get rid of it. We want you guys to keep it going. And for that, we're talking to you guys about value-based purchasing that's coming into play in 2021. We want you guys to be ready for those contracts and get, that billing piece under your belt so you guys can be reimbursed for the services that you guys aren't currently being reimbursed for and create that sustainability within your organization. Hiring new staff. There was some issues. So in the beginning, I said there was, some organizations were able to, but others, more in the rural areas, Dayton, Pomeroy, more in those areas. They're really rural, so getting people to come and work for them is difficult. It's not attractive. If you have ever been to those places, you just drive by. If you blink, you miss it. And it's
to blink 3 times.
3 times for some. But those organizations that are having the staffing issues, they really have to get creative on how they can utilize their staff to work to their full potential to cover all of the patients and the services that that need staffing. And this, I'm saying this more for Garfield County Hospital and Pomeroy Medical Clinic. They, have been having a lot of staff issues and turnovers. So that's another reason why. And then, as far as cohort 1, that's kind of the really, really high overview of where organizations currently sit for quarter 3, which is a lot of improvement from quarter 1, 2, and 3. And we're hoping that by quarter 4, all these lines are green. And I just say, look at them, they're green, we're good to go. But there's some work that has to go behind that from our part and from your guys' part as well. So this is cohort 1. We have, if you guys are aware, we have a second cohort that Carol mentioned, and their first quarter started in July, so they had July, August, and September as quarter 1. And on here, it's the same layout. We have the 4 projectors at the top, we have the color coding, and we have the sites on the left-hand column. And for bidirectional integration, cohort 2 is made up of behavioral health and substance use disorder organizations. So for them, some already had co-location there, or they're using the AIMS or using the Broom Collaborative. For cohort 2, we created some flexibility as far as the type of integration that they are willing to make. If you see here for Merit, they are integrating substance use disorder with behavioral health. And then if you keep scrolling down, Tri-Cities Community Health, they are integrated into the Pasadena School District. Serenity Point are integrated into Walla Walla Jail, which is awesome. And then there's more co-location. Bloom on Counseling, they are located in Dayton. They are using telehealth as their integration. And then what else? I believe for the most part, there's one that they have an MOU with the doctor, so not specifically co-location. They're just sending their patients to that doctor which they have a memorandum of understanding. Hey, seeing our patients, him specifically, he's going to be seeing the patients that are diabetic, and he also sees the patients that are in MAT treatment for trying.
So, Martin, I have a question for you in regards to telehealth.
Mm-hmm.
Have you seen any organizations that are doing peer-to-peer telehealth, like family practice to behavioral specialists, where they consult with each other?
In the model, the telehealth, Blue Mountain Counseling, the model they're going for that model. So the provider is going to be present in the room with the patient. Some services of telehealth is just the provider and the patient, just looking at them through the screen, but nobody else kind of by their side to take notes or kind of explain to that patient, what the other provider is trying to tell them. But Blue Mountain Counseling is going for that model. They're going to have their ARMP be present in the room when the patient's receiving telehealth. And then the next section is transitional care. And in this section, like I told you guys will see a lot of yellow. And that's because we just started working with the MCOs, not just, but a couple months ago, on getting this cohort connected with collective ambulatory or collective medical. And if you scroll down, Chelsea, you guys will see a lot of yellow on this. There are some organizations that are already doing it, and that's because they are part of an FQHC, or the MCO was quick to get them access to this service. And then scroll up. The next one's opioid crisis, and this one, I believe, for the most part, everybody is yellow as well. This, for a lot of them, a pharmacist is not possible, and that's because they're small organizations, too expensive, but they are doing some type of medication management of the patients. They either have a provider on site that's doing it, or staff are doing the medication management some other way. And again, this is quarter one, so we didn't ask for any numbers, any data, it's just selection. So a lot of them are going to be green in quarter one. Quarter two, there might be some color changes, because that's, when we require at least some numbers to show, hey, you guys are implementing this or are in the process of implementing. So some color changes might change for quarter two. Then the next one, chronic disease and self-management and prevention. I believe for this one, everybody is green as well. Yes, good. They do have some type of way that they are tackling chronic diseases within their patients, either to those high-risk patients that they are providing extra opportunities, they're providing self-management on some conditions, diabetes, depression, anxiety, substance use, whatever conditions they pick to track. And then, of course, in their clinical quality metrics that they chose to be tracking for the remainder of the rest of the 3 quarters that are left. And then on the right-hand column, you guys will see the barriers for cohort 2, and there's some overlap on both. Cohort 1 and cohort 2, staff turnover, recruiting areas, LSCW, case management, through the workforce meetings that we've had, and just, people telling us workforce for behavioral health is in a big shortage. So that's a big barrier for these organizations.
We're working on it.
But we are working on it. Carol has some big news that are going to come down later in another meeting. But we are working on tackling the workforce issue. Technology implementation planned for later in the year that will allow for risk stratification, patient rostering, population health management. A lot of this risk stratification, empanelment, patient rostering is new to behavioral health and substance use, that there's some learning and making sure that their EHRs are set up to track this. And we have identified some organizations that will need some help, with their EHRs, because they are either not compliant or ONC certified, which is a requirement as part of a milestone 8. that, that can hinder them in this area. But we're working to get them either onto new systems, or we are working with the EHR vendor to get them be ONC certified in certain areas that will meet the milestones that we have. And Sam's working on that. EMR transitions, again, that learning curve, 42 CFR, sharing information from behavioral health to PCP or PCP to behavioral health. That was a barrier as well on the cohort 1. And then opportunity to enhance billing workflows that will
allow for sustainability.
That's another overflow from cohort 1. We want organizations to be sustainable in the work that they are implementing in their sites. Any questions? So that's a quick rundown of cohort 1 and cohort 2 and all the progress that they have made, either through almost their first full year of transformation or the first quarter.
Okay,
You're
Jenna. All right.
So we're going to go through some proposed changes and updates to our 2020 practice transformation. So this would be ideally what year 2 would look like for all of our practice transformation organizations. As y'all know, we have 3 years worth of funding to provide. And so we always presented, I think from our very first kickoff, we presented practice transformation this year as like baby step. Foundational, level 1, and we always said like this will probably ramp up in future years, so this is kind of the manifestation of that probably. We definitely want to get your opinions on it and see what you think about it, so I'll just kind of walk through the crosswalk. Chelsea has it up on the screen, and just kind of give a pause after each one to get some feedback, and if we just get like universal head nodding and silence, we'll think it's good. Basically, the first one is milestone 2A1, empanelment. We're basically right now, empanelment is required for 95% of the patient population, and we're going to make that mandatory in 2020. It's basically mandatory now, but this next year we're just going to say you absolutely have to be doing empanelment for 95% of your population and provide that status in numerator and denominator. So it's nothing different from what our sites are doing right now. We're just saying absolute, like this is non-negotiable. Yes.
The denominator?
It's all of your active patients. So active is determined by each organization. Some people do 2 years, some people do 3 years. So it's all of your active patients, and your numerator are the patients that are assigned to a provider or clinician in your EHR.
The definition of active patient. So it's not the list that they might receive from the MCO monthly benefit. So it's people that have already maybe established care.
Mm-hmm.
So that's what we're measuring?
Yes.
How many people that have established care are assigned to a primary care?
Correct.
Not people that are on their list that they haven't reached out to yet?
Correct.
The rosters don't always correspond to reality in terms of patient behavior. I mean, we've seen that over and over again. Patients go where they want to go regardless of where they're rostered.
Can you repeat that comment?
That's my question. Because those are your highest cost folks.
Yeah, and so for those on the phone, Wes just said the rosters don't always match what's happening at the practice, just so y'all can hear that comment.
So just to flesh out what you were just saying, Becky, the ones that don't go to the provider tend to be the most expensive. Is that what you're saying?
So who's accountable for those?
Can you repeat the patients that don't go to the provider are the most expensive?
Yeah, so you're asking on this milestone, you're saying of the people that walk through your door, how many have you assigned to a primary care?
Correct.
But what I want to know is, of the roster you receive every month of the people that you're responsible for, how many of those have you reached out to and helped get established primary care?
I think a question we would have to ask our sites first is how many of those sites actually check those rosters and go off of them and do like a crosswalk for how many of those patients are actually assigned to them. So we brought this up a little bit last year, and I think it's a great idea. It needs to be done. But we brought this up last year, and they're like, oh, we don't get those. Like that was kind of the universal response, is that we don't get those, or we don't check those. So
they get those.
Yeah.
They do get them.
They might not know they get those. Yeah.
Yeah. So to me, to me that maybe the next year or something. You know, I don't know, but to me, that would be our end goal, is to identify it's all about accountability. Who's accountable for those patients?
And I feel that, through this work, the empanelment piece, those patients, say they present themselves to, Tri-Cities Community Health. If they're not established, they do try to establish that patient so that they can continue receiving care at Tri-Cities Community Health.
So eventually,
This is Ed with Comprehensive. I understood on the primary behavioral health centers, that this included also people who were assigned to a multidisciplinary team within the organization from their intake admission.
Empanelment is all patients for that site.
Correct. So somebody had said assignment to primary care, but this also included, within behavioral health clinics, empanelment included assignment to a multidisciplinary team within the organization, correct?
Correct, yes.
I don't think the behavioral health agencies get rosters.
Wes, why don't you grab that microphone so other people can hear you talk?
So my response is, and this is more of a question, do the behavioral health agencies So, does this work?
Yep.
So, I can barely hear it. So, do the behavioral health agencies get empanelment rosters from the managed care organizations?
Not to the best of my knowledge. Remember, I think at a learning collaborative or a leadership council meeting where the MCOs spoke about a different topic, I asked why they have not assigned patients to behavioral health organizations, and they said they have not done that. My understanding is they've not done that yet. They somehow thought it was too complicated.
We could ask Kat.
Yeah.
Kat's on the line. Kat, do you have a response to that question?
Yeah, so at this point in time, no, we do not assign the individuals to behavioral health. Currently, those individuals are assigned to primary care providers. I think at this point in time, it is a requirement from the healthcare authority to have a primary care assignment, and it also is best practice. I think we are still looking into how do you move into that space within an integrated approach to have assignment in both areas. But at this point in time, no, we do not assign individuals to behavioral health providers.
Thank you. This is Ed again. That's kind of why I wanted to ask the clarifying question. So for the behavioral health providers, my understanding, and I can be mistaken, was that we were being asked to track how many people who came through the door. It resulted in an assignment to a provider or a behavioral health clinician, so that we're working towards having some kind of metric of who's making it into care. And then when we do get to a state where we can look at the attribution, then we can match those rosters. But because this is a payment milestone in our agreement, I thought we had a addition that applied to the behavioral health folks as well. That's just what I was trying to clarify.
Yeah, and Ed, you're correct. It's of those active patients, how many are assigned to a clinician, and that could be a LICSW, a counselor, whatever your structure looks like. If you have a multiple disciplinary team, it could be that team if that's what you have. If you're a primary care site, then it could be your primary care provider. And the discussion that we're having is kind of taking that to the next level and saying, okay, you know what your empanelment is internally, but what about when it compares to the MCO roster? That's kind of the question on the floor.
Got it. And I think your step that you took last year helps us be prepared for that.
Thank you.
Is your comment?
Yeah. This is real brief.
It is.
And I don't think we probably do a great job of our current roster management, but we're managing care gaps on a roster.
Can you guys hear Liz on the phone?
No.
Can you hear Liz?
Not at all.
Yeah, use your microphone. Thank you.
So I was just making the comment that roster management is really resource intensive, and we take an approach of closing care gaps as our roster management, although I think we missed some elements, but we're trying to ensure that patients that they receive, that we're meeting, the screening and looking at those care gaps.
I completely agree. I know there's some organizations that do a good job of managing their rosters, but that's a whole department is just MCO assignment, looking at like that's their whole FTE. So.
It's just, this is Becky, yeah. I think of the primary care, and this is all my years of managed care, but I think of primary care as the hub. And when we have no hub, then it makes it very difficult to go to someone who is accountable to talk about, maybe they haven't walked through the doors of that primary care, but they can be part of this, they should be the hub of the discussion about how to provide care for that individual, whether these folks are behavioral health and SUD and infectious disease, whatever, but somebody has to be the hub. And so, you know, we can see on a list that the MCO says you're the hub, right? But if nobody's looking at that roster, then when I call and say, hey, I want to be a part of this problem solving on this individual, we don't know this guy, you know, kind of thing. And there's no really great effort at, oh, I guess I am the primary care. Okay, let me step up and, you know, even though we don't know this individual, be a part of the problem solving. So to me, that's the gap that hopefully we can move towards. I know it's difficult. I'm not saying it's not difficult. I'm just saying that it's something that has to happen, and it's definitely missing in these really high-cost, complex individuals.
So a few years ago, I had a conversation with a chief medical officer who was actually a former group health medical director. And his comment was he would like to see that everybody on that roster comes in to the clinic at least once a year. And that benefits them because if they have a chronic condition, they get re-diagnosed, and that affects their capitation payments. So in general, I mean, working off of those rosters, I think that there is some utility of that. If the patient doesn't want to come in, that's their prerogative, but at least they're doing outreach to make sure what you're talking about, Becky. There's individuals with high utilization that are not coming into the primary care practice. They at least get to see.
Or they can at least be part of the discussion. Just because the patient is seen by the primary care doesn't mean they can't be part of the discussion or part of the, you know, plan. Because as we move into telemedicine, we're going to have more options. We need to lay that framework so that they're held accountable. Who's number one? Who's accountable?
Completely agree.
I think it's a very small way to affect that gap. Are for the patients that don't have a primary or haven't seen their primary, since they don't have a primary at all, but they're high risk, they end up at the ED, right? And so if if the ED is connecting that patient to a primary after the ED visit, there is a slight thread between that high utilization ED and the ongoing primary care. And then I'm assuming the primary care is responsible to contact that patient. So that I don't think that's a situation at all, but it is a step towards grabbing those high-risk patients that end up in the ED without a primary.
Yeah, there's just a couple barriers.
Oh, lots.
Because, you know, they don't always know who it is, right? Because they don't have the tools to look it up. And even if they do know and they send it on, a lot of times the clinics say, well, I haven't seen that patient. You know, the number or, you know.
It looks like we have a comment in the chat box.
We gotta keep moving towards that.
So what's the comment?
I
Hard
cannot
to
see
read.
that far.
Okay. And then Dr. Martin had a comment too.
I did?
Oh, all right.
I just said I was.
Should be a proactive two-step approach. Practices should be verified insurance card each visit and identifying the primary care in addition to a proactive approach to personnel roster.
All right, let's keep going.
Okay. All right, number 2. So we have risk stratification, and it says of the 95% impaneled in the site, the goal is to achieve at least 75, risk stratification of at least 75% and do care management for 80% of those patients. And so you'll notice on the right-hand column in the red is what we changed. We would like to have risk stratification of at least 85% of those impaneled patients and provide care management to at least 95%. So I will pause for comment.
This is Rick George. I have a quick comment on that. Can you hear me?
Go ahead. Yes.
Okay. If we risk stratify, if we take the 95% of impaneled patients, that's thousands of patients. The bottom rung of those patients are not going to be identified as high risk. The way we're approaching it is we're looking at, if you had 1,000 patients, the top 100 patients would be our highest risk. So those who reside at the bottom of that list don't necessarily need additional care management, in my opinion.
And that's fine, because in the reporting portal, we have the list where it says highest stratum, second, and then it goes all the way down to low to no risk. So that's where you could just put those 900 patients in that low to no risk column. Now, it's up to them, and so it's based on their patient population. And so if we have a site who... Okay. If we have a site...
Your statement here says that you must provide care management to 80% of those people.
So that's 80% of those patients at highest risk. So it's exactly how it is now. So that 100 patients that you referenced, it would be 80% of that 100, so 80 patients. And so now it would be an additional 15, 95.
Okay, that makes sense.
If you rephrase, that makes sense. It just, in the phrasing on the screen, it just seems to that. I was just going to make the same comment, this cat. Maybe just some of the wording could be just slightly clarified to clarify that.
Yeah. Okay, and we kind of tried to make this a little smaller. We can add that language. It's the same as it is on the CSI platform. It's just we tried to make it fit in the box, so we can. Yes.
There's some wordage that's missing here because it's taken a little bit out of context when you, like you're saying, when you see it in the platform, it has that additional language about the risk stratum that it pertains to.
Yeah. And Becky, did your question get answered?
Well, I would just want to make sure that there's some consistency across the organizations on how they risk stratify. Because if one clinic risk stratifies everybody alone, so nobody needs care management, and somebody else risk stratifies different, then, you know, some are going to meet, some aren't, maybe.
Oh, me and Martine shut that down. Just joking, kind of joking. So basically, we'll have sites that'll be like, oh, our top risk stratification is 5 patients, and we're like, you can do better than 5. Let's add some more specific criteria, but we do want to leave it up to them, like what diseases or conditions they choose to risk stratify. That's one thing we want to leave up to them, but if they come out with like 2 patients in their highest risk stratum, we're like, okay, let's talk about it. Okay. All right, next one. Identify the types of data your practice uses to risk stratify. So this is in the workbook. They have a selection. It's a big, long list, which is why we didn't put it in here, but of how they want to risk stratify their patients. What we're proposing in 2020 is to make social determinants of health, SDOH, screening mandatory. Thoughts? Claps. Yes.
So I have a question. Are you saying that we would use the social determinants of health tool for all patients that we're risk stratifying? I'm not sure how we use that.
Yeah, good question. So it would be taking that SDOH screener and just doing it like how you would do like the PHQ-9s once a year, like GAD-7s once a year, adding that social determinants of health screener. And so I don't know if you're thinking of a particular one, but the reason we like this so much was because Providence has already implemented it, and theirs is just a quick little fourth a sheet that says housing, and then it gets passed off to, I forget the title, basically their social worker who can help with that.
And so we would use that tool for all the patients that are impaneled, or just those that are in a certain group?
I would think it would be all the patients that are impaneled doing that social determinant screener. Yes.
We're actually discussing that now.
I'm sorry, what was that?
We're discussing the use of a tool for social determinants of health. Sorry.
Yep.
What the cadence would be, and one of the suggestions was that every new patient that comes through the door has an assessment done as part of their uptake.
Okay.
When new patient assessment. We haven't really decided as to what the actual cadence is.
Okay.
That's one of the discussions.
So will you send us the tool that Providence is using?
I can, yes. I can send the tool that Providence is using for those who didn't hear Barb's question.
Is it the prepare tool?
No. No. Yes.
That's pretty extensive.
All right. Next is milestone 2A question 2. So we're basically asking in this one, using the data types above, your practice will provide a concise narrative describing the approach, methodology, or tools used to risk stratify patients and how this information is recorded in the EHR. We're just basically saying that giving a narrative in 2020 is required. We have some sites that just select what their risk stratification is and give data. We're just saying we want to have that, just a little more information in 2020 to help us out. Questions, thoughts? Okay. Next one, use the information to record the total number of patients in each risk stratum and the number of patients within the stratum that received care management during the reporting quarter. Mandatory, so basically reporting is mandatory. Some of these are just kind of gimmies. We just wanted to make sure that was in there. So opportunities for those at highest risk. We just have a list right now that has maybe 10 options on there to select additional opportunities, and these are very simple options for those of you who don't have the workbook memorized. And it's just like having a plan of care for patients, including family, including patient experience and patient voice, things like that, things that most sites are doing. And so what we wanted to do was conducting a team-based huddle be a mandatory selection in 2020. Thoughts on team-based huddles? That's a good question. Ideally, they're done daily, like having like a little 5-minute daily huddle before the day starts, looking at your schedule for that day. So that could be our frequency. This is where we also want input from this group.
What would be a reasonable weekly? Weekly, yes. Weekly, doesn't make any sense to do it.
I agree.
Okay.
I think daily is kind of best practice, so, okay. We can make that as a note. Okay.
That sounded like a fascinating conversation, but those of us on the line have no idea what was said.
Oh, sorry.
Sorry. I asked.
Yeah, basically, I read the question, and then a question of frequency was posed, like how often will huddles be a requirement? Should it be daily? Bill Dunwoody said the minimum should be weekly. That makes the most sense, and we said daily was best practice, so I think we're going to land on daily as the requirement for that. I'm seeing no strong objections in the room. I'm going to narrate and say, like, what's going on. Okay. The next one is 2B1, bidirectional integration, question number 2. So choosing an evidence-based instrument or tool used to systematically assess patients and monitor or adjust care. We would like to add a data component to this, so we want to know how many patients were screened. So what often happens in this question is that there's a GAD-7, a PHQ-9 used, Columbia Suicide Severity Rating Scale is used. We want to know how many of those patients actually got that. And when we were talking about this, I've mentioned from past experience, we'll say, oh, we're using this new screener, and it's like verbally adopted, but not actually adopted. So we want to see what those numbers are.
I want to go back to the huddle question. So I'm trying to think about this in a very practical way in the clinic. less for the hospital, because the hospital is sort of huddle every day anyway.
Yeah.
But for the clinic, we want to be focusing on the highest risk patients, right? That's what those at highest risk. That's what the criteria says.
That is a good point. Yep.
Okay, so if I'm a provider and I'm not seeing any, I mean, I may do a huddle,
Mm-hmm.
but if there's no high risk patient, then I'm huddling about other patients. Do you want that recorded? How are we going
Barb,
to?
this is Ed. Maybe let me take a shot at this one, because I think it dovetails into the empanelment question. And when we look at those high risk, from a behavioral health perspective, if we look at those high risk patients who hit our system, they tend to hit through key assignments for us or programs. And for you, I think it's probably very similar in that they are probably enrolled or assigned to a PAC team, or they are probably enrolled or have had contact with the DCR team, or they are probably under case staffing and referral from the inpatient team. So I think this for behavioral health entities, this may link very strongly to our empanelment to help us select the huddle population.
I'm with you, Ed. I think that makes sense for behavioral health. I'm also thinking about
primary care
clinics. So if one of the areas we're looking at is patients that have diabetes with a really high A1C, they're at highest risk. First of all, if they're not seen if they're not going to be seen that day, then they're not going to be huddled about, right?
Correct.
So are we huddling on all patients then? That's the first question. And the second question is, how are we recording that so that 6 months from now or 3 months from now, the GCACH is able to say, yes, I can see you've huddled on all these patients once a day.
I think, so to answer the two questions, I think we have opportunity to change the language here so that it could be huddling for all patients, because that's the goal, is to just have like a daily huddle with your primary care, MA, nurse, whatever that team looks like, to have that huddle. And I know that we have some exemplar organizations that do this currently and have a tracker for it, so that might be somewhere where we can lean on resources rather than trying to recreate the wheel and see what has worked for them. So we can make that as a note, unless anybody else has any other comment on huddles.
So is that what are the other options?
You're testing my memory of the whole table.
Additional opportunities, I guess.
Yes. Mike Martin, do you have it? So there's about 10 options. One is, I know the very first one is provide a personalized plan of care for each patient. And that's pretty much all I can remember off the top of my head from that list of 10. Give us 1 second.
Because to me, why did you choose team-based huddle as mandatory selection versus the other 9?
Well, team-based, just because we saw the value in it, is being able to prep for that patient and know who's coming in, have that like time ahead to say, okay, Mrs. So-and-so is coming in, she's struggling with her diabetes, she has this and that care gap, so that way the team is prepared. And we've been able to see, and not just in our region, but it's like best practice nationally to do a huddle with your team. It's actually required for some of the FQHC to do that huddle. And so there's many positive outcomes that come from it. That's why we focused on that one. But the options, so it's use a personalized plan of care, manage meds to maximize therapeutic benefits and patient safety at lowest cost, proactively manage chronic and preventative care for empaneled patients, use team-based care to meet patient needs effectively, use care management pathways appropriate to the risk status of each patient, manage care across transitions, use evidence-based pathways for care, integrate culturally competent self-management support into care, involve patient and family in decision-making in all aspects of care. So as I read that, most of the time we get nods and people are like, oh yeah, we do that, this is normal. And so we just thought a mandatory one would be team huddles because there's been so much benefit from it. Sam.
Barbara. This is Sam. On one of the examples of that is for Central Washington. And Central Washington has their behavioral health integrated therapist that goes around in huddles with the primary care in the morning just to identify patients that might need that warm handoff. maybe that they've got a new diagnosis of diabetes or something like that, that they would benefit from the behavioral health therapist doing that warm handoff quickly so that they're already identified patients prior to the day start.
Yep, thanks, Sam.
All right. So we talked about, just kidding.
From a lean perspective, a huddle is generally what happened yesterday, when we were lessons learned from yesterday.
Mm-hmm.
What do we have to prepare for today? So it's the patients that we're going to be seeing today.
Correct.
Mrs. Jones is going to be seen today. She was in the emergency twice a day last week.
Correct.
Mr. Smith is having a problem with his diabetes.
Correct.
So it's specific to individual at-risk patients. So the at-risk patients could be those who have specific diagnosis and so forth. But those patients that you're going to see today, that's really the issue. Within 24 hours.
Something in that day.
Okay. Any chat box questions we need to address or anything else on that one? Dr. Martin, did you have a question?
Just, it sounded like an interesting conversation. Couldn't hear it.
I'll narrate. We described what a huddle was and what it wasn't. Sam jumped on and said how it looks like for CHCW.
Heard everything up to Sam, and after that it was muddled.
Oh, okay. So we just talked about what a huddle is and what it isn't, and that it's usually at the beginning of the day, quick lessons learned, and then who's coming in. How do we prep for that? And so we also might have an opportunity to add language on what a huddle is and isn't as we add that question.
And this is Dan, and not to get too muddled or into the weeds, but I'd be curious, is there opportunity to define kind of the quality of the huddle and whether or not there's kind of what you're hoping to accomplish actually happens? And is that something that's necessary?
I don't think that's too into the weeds for this group.
That goes back to one of the, right into the mic. That goes back to one of the milestones is that you are evaluating patients on a monthly basis.
Correct.
Maybe it's a monthly or quarterly basis you're regrouping on these patients to ensure that it's caring for them appropriately.
Okay.
Currently, right now, we're trying to do that. We huddle the week before the patient's coming in, within a week of the patient coming in. Then we have the interventions during that visit, and the following week we're following up.
Okay. It's a good cadence.
Could you repeat that, Jenna?
That was a lot to repeat. Basically, that was Liz from Tri-Cities Community Health, and she just talked about what their huddles look like, and how they look at a patient before they come in, when they come in, and then check and see if there was a follow-up outcome from what happened once after that patient came in. So basically, they have kind of like a 3-system checkpoint. Am I saying that right? To see basically what was the outcome of their patient and was what they're doing effective, all their prep, was it effective?
Thank you.
Welcome. All right. Next one. Okay. 2B1, question 13. I don't think I skipped one. No? Okay. Identification and outreach to patients lost to follow up. So this question is basically in the workbook. If patients fall off the face of the earth, they're in the middle of treatment, and they just stop showing up, who does it? So right now they just say, who does it? And what we're asking is to add a data component, so the percentage of those patients that were lost and that received a follow-up call. So we just want to know, now we know your front office staff makes those phone calls, how many of your patients that stopped showing up actually got a phone call? So we want to put some numbers to it. Thoughts, comments?
I just see a lot of variability among our clinical partners, actually
Okay.
To see a lot of variability on our clinical partners on what follow actually means. So
Okay.
criteria or guidance.
We definitely can.
Checkbox.
Yeah, we definitely can. I think it should be a phone call, and I know I've seen it where there's attempts. Yeah, where there's multiple attempts to make the call. So 3 could be, I think, is usually a thing. And so sometimes it'll be the first phone call, and it's like called at noon, patient didn't answer. They'll try again later in the day or earlier in the morning. So we can make that specific. I think that's a good takeaway. So.
The language piece. I think the language piece as to adding the language piece is important to bring up because you know you guys are hitting, you guys are right. A lot of the places, they have different meanings as to what that specific thing is. That having that language say this is what we're looking for, I feel that's really beneficial to us and to them.
Yeah.
Because that kind of gives them a clear, okay, this is what we're going for instead of, oh, we think this is this, but you guys are saying it's this. So that way, they have, their sides in front of them.
I agree. Okay, so moving on to the next one is 2B1 question 15. What measures will you use to assess the integration of behavioral health and the impact of behavioral health services on your population? So this question is at the end of the bidirectional integration section, and basically it's a very long question that just says prove it. Like how are you going to know that this is working? And so we want to actually have them prove it, not just say we're going to look at PHQ-9 score trends over the year for the patient, but say what were those scores? Did they go from a 22 to a 20? Just being able to provide some data to that, and they set what their hi, we're all awake. They set what their how they're going to track the impact, and so we just want to know the associated data with that. Comments, questions, feedback. Seeing universal nods. Move on. All right, 2B1 question 16, how have you increased your practice capacity to implement this program in the past quarter? This is where we would like to kind of work smarter for ourselves as an ACH, so we would like to add a mandatory MAT training or MAT referral source as an option there, and also add an option for our opioid resource network. So we thought that was a pretty good layup for the work that we're doing as an ACH to add the ORN as an option. So we know MAT services are where healthcare is trending. It's being proven effective. We want to give that as a mandatory option, not saying that they have to have their providers waivered and certified and all those things, but that they at least have to have a referral source, or they can easily work with the ORN in their region. So, thoughts?
So that addition is 1 or 2. It's not 1 and 2.
It's either or.
Either or, yes. Thank you. Clarifying question. All right, so 2B2, self-management support. This is questions 2 and 3. For those of you that are familiar with the workbook and the reporting portal, these questions are kind of combined. So it says, what high-risk conditions are the focus for self-management support in your practice? And then how many patients received it? So what we're asking our sites to do is say, what are you focusing on for self-management? A lot of the time it's depression, diabetes, hypertension, things like that. And then how many patients got a self-management support, got that self-management support? We have no threshold on that right now, which a lot of our sites have appreciated this year. But in year 2, we would like to add a minimum of 10% to receive self-management support. So if you have 100 patients that had diabetes at your specified level of 10 or above for A1C, at least 10 of those patients would get self-management support. Got some universal nods and page turning. All right, 2B2 question 5, what approach are you using to assist patients in assessing their need for self-management? We would like to have the PAM be mandatory if the organization is interested in becoming a health home. Thoughts?
Otherwise,
the PAM is not mandatory.
PAM goes along with the health home anyway. This just puts it into writing.
Wes specified that the PAM goes along with the health home model anyway. Narrator extraordinaire. Okay, 2B2 question 10. What measures are you using to track the impact of support for self-management on care processes, health outcomes, or costs for the conditions that you identified? Yet again, we're saying prove it to our sites. And so we want some data around that. How has your self-management actually improved patient outcomes? So we'd like to see some data. Thoughts? All right. 2B3,
Jenna.
we moved on to
Jenna, this is Rick. Can I go back one item to the health home, the PAM issue?
Yes.
All right. So we already provide health home care coordinating services as an agency, and that program uses the PAM. However, we do not use the PAM agency-wide. Are you suggesting a mandatory utilization of PAM simply because we have health homes as part of our array of services?
No, Rick, this is Sam. That is specified to your specific patients that we know that are identified outside the organization for the ones that you must utilize this health home. So no, but it would be just associated to the patients that are enrolled in the health home.
Okay, thank you.
You're welcome.
So this is Brian. Can you hear me?
Go ahead, Brian.
Can you hear me? I'm going to push back on the PAM a little bit. You can do self-management without doing the PAM. I feel like it's not super conducive to primary care, and it tends to be somewhat, how do I say it? It can be uncoordinated as a part of self-management. So I'm going to push back on that a little bit.
Does your pushback take into account that we're asking for the PAM to be mandatory only if the organization is interested in becoming a health home?
Can you explain that further? I mean, are you talking about, we're already PCMH, right?
Let me make a comment to that, Jenna. This is Rick again. So the PAM is an automatic tool used within the health home program. It's provided to us, as I understand it, through the MCOs to move that forward. If we were to move it beyond the health home program, we have to purchase it as a product. And that purchase is something we evaluated a few months ago and made a decision not to do it because we have our own self-management tool that we've implemented that we find to be satisfactory. So, I agree with Brian on this issue. The pushback on this is it's not the only method to get to a good self-management construct for our clients.
Okay, I feel like we have
we already have a workflow in place that has been pretty successful for self-management. So I'm going to push back on it. I just don't think it should be mandatory. I think that there should be some flexibility in how self-management is getting done. And also think that we need to take into effect cultural factors. And there have been some pieces that have come out about the PAM and cultural factors.
Becky.
Oh, okay. I think this is just a redundancy.
Okay.
I think that if they are health home, they know they have to do the PAM.
Okay.
So I would just remove that. I think it's confusing.
There's a redundancy.
Okay, so would that satisfy all parties? If you are a health home, you are required to do the PAM. Therefore, we do not need to mandate that health homes do the PAM in practice transformation.
That seems like an accurate statement.
But the goal of this was try to get those organizations who aren't health homes, the ones that are interested in becoming a health home.
That is a good point.
Right.
So I don't know.
But if they enter into a contractual agreement with the MCO to do that, that'll be in their contract with the MCOs to use it. I think you were just trying to capture this. If you're a health home, this is a contractual requirement.
Sam, what are your thoughts?
Well, I think the whole conversation was around when Wes was under the understanding that if we were going to assist entities in becoming a certified health home, or that that would be one of the implementation tools that we could assist them with under the MCO auspice.
So I think the question kind of on the table is if we're assisting them in becoming a health home and using the PAM as mandatory in that agreement or contract to become a health home, do we need to specify it in our year 2 workbook? And I'm seeing some head nods no.
I'd like to make a comment again on this one. This is Rick. The health home program has very, very tight margins in terms of how it works. And the volume of referral clients that are coming from the NCOs currently is not going up, it's going down, and they're not quite sure why. So I would strongly suggest that you talk to the folks leading health home services on whether or not that is going to be a good plan for our region, adding additional health home workers. And I'll leave it at that.
Carol, can you give your input on the knowledge that of where we might go as a state? Can you share that information?
Carol is not present at the moment.
So to add a comment about this, Healthcare Authority and the Department of Social... Wait. Sorry, a little premature. So the Healthcare Authority and DSHS are very supportive of the health homes. Stephen Mancuso, I don't think he's with DSHS anymore. He's an economist and did a lot of analysis to look at the cost effectiveness and the return on investment for doing health homes. And it's always been positive in their minds as being productive and producing good outcomes. So they have pushed and continue to push the health homes, and we're trying to be supportive of that in ways that are reasonable. So by incorporating it into this particular milestone, as Jenna had started to say, it's a way of providing incentives to organizations, even though the numbers may be declining. And I hadn't heard that before, Rick, and I don't know why that's happening. But in spite of that, I think it's something for now that we do want to try to support where it makes sense in organizations. So it might be a little redundant, but it provides some incentive for organizations to try to pursue that particular model of care. And it provides them with additional information such as PRISM scores that are provided by the MCOs that they may not be able to access anyway, and that can help them with their risk stratification processes, which we've already talked about.
So what it sounds like is that we need to table this and maybe come back with like a follow-up email or something on what our thoughts are, since Carol isn't in the room, possibly. Okay. All right. So 2B2 question 10, what measures are you using to, did that one. We jumped back, sorry guys. Medication management, question 2, milestone 2B3. What comprehensive medication management services does your practice provide? This should include med reconciliation and additional services. We would like to propose that med reconciliation will be mandatory. I don't know of a site that isn't doing med reconciliation if they are prescribers. So we don't think that one would be too hard. Thought.
The question is this standard of med reconciliation require certain providers, a certain level of staffing to do? Like, can an MA do med rec and review with a primary care? Or does the primary care have to literally do the med rec? How is the pharmacist involved? Or are you just leaving it open for us?
I believe it was open, but I'll defer to Sam right now.
Yes, an MA can actually do the med reconciliation if that's the internal process of the organization, and typically that's how it is. It's reviewed by the MA at the intake, and then any questions are coming from primary care in regards to that.
For anybody that's on Cerner, which would be at least all of Virginia Mason, you can't write a prescription until you've done a med rec.
Okay. Good stuff. All right, next one, 2B3, question 3. How does your practice engage pharmacists as part of the care team? So we're saying engaging pharmacists will be mandatory in 2020, meaning collaborated, integrated, contractual, or telepharmacy. And so we really tried to be sensitive in this question to people that maybe like your standalone SUD providers that don't have a contract pharmacist and would probably but likely not have one. And so we just want them to have a relationship with a pharmacist. This can be, I know for Catholic Charities, they were looking into a relationship with Safeway. So this doesn't have to be very complicated. We're not saying you have to go buy a clinical pharmacist and put them on your staff. We just want you to have engagement with a pharmacist. Thoughts? Nods. Okay, good. Does your practice provide collaborative drug therapy management? This, we're proposing, would be mandatory in 2020 for contracted or staffed pharmacists. So this one is saying if you have your internal pharmacy on site, are you doing some kind of talks with your primary care provider to your pharmacist saying, okay, Jenna's on her insulin, she might need to have her insulin titrated, like having that pharmacist input into medication. And this is yet again just for people that have that like staffed or contracted, somebody on site, ideally pharmacist, to be able to do that. So thoughts or feedback? The ones I'm expecting pushback, I get none. Okay.
Sorry. It's really a relationship between the providers and the pharmacists, and I think most of the providers are willing to give up that limited activity to the pharmacists without a problem.
Oh, yeah. Okay, good stuff. All right, milestone 4, patient-centered interactions. Question 1, we give an option here to either conduct a survey, do a patient and family advisory council, or a PFAC, or do both. And so for option A, we'd like to adjust where it says conduct a monthly based practice survey of their patients to have a minimum of 25% of patients that were seen in that quarter receive surveys. So we tried to be very specific on that language. So if you see, easy math, 100 patients in 3 months, 25 of those patients will get a survey. Thoughts? Yeah, they should be, because most of our sites are using Crossroads, are contracted with someone who gives them that information, and they know their patient volume, or they're doing it some on iPads, like when patients do check out, so they could easily compare like how many surveys were sent out to what their patient or client volume was in that quarter. Thoughts? Other thoughts?
I don't think that Crossroads is doing 25% of the patients seen, however.
Okay.
Kat, are you on the phone?
Crossroads is only doing 5-6 surveys per provider.
Isn't that to CHPW? Kat?
I think I saw.
You left a little while ago.
So maybe we could have a clause here, Sam, this is where your feedback, 25% seen in the survey or statistical significance, which I think is what, an N of 30 for surveys? Just a thought.
So, and are you trying to mandate a minimum return rate or an offering rate?
An offering rate.
An offering rate.
You should clarify that.
Okay. So Sam, what did you think of the statistical significance for those sites that do have like Crossroads doing a set number of surveys per provider?
Well, what we're hearing is that they're only reaching out to these larger organizations, 6 individuals at a time per quarter. And so we're kind of wondering where the significance or even what value they're getting from that 6 individuals when they have thousands of patients in that quarter that are being seen.
That's 6 individuals per provider, though.
Is it 6 because when they're reporting it, they're only reporting it as 6 patients were reached out to for the total organization.
No. I mean, I know in our case, it's 6 per provider. So typically in a quarter, that may be up to 600 or so.
Okay, so it sounds like we have some reporting issues with some of our entities as opposed to what that might really truly look like. So I'll send an to talk to them.
Yeah, I got clarification from that. I know what organization you're talking about. I got clarification. Okay. It's 6 per provider.
Okay. Well, then we need to, I appreciate the clarification on that because, yeah, we were really concerned when we were looking at the reporting and it was only showing that 6 patients were being reached out to per quarter.
Okay.
Medical or behavioral health services?
I think it's going to be by site. So whichever site you're contracted with, because I know TCCH, y'all have the 2 just primary care sites and then your behavioral health. So it would be of those sites, 25% of the patients that were seen that quarter would receive a survey.
That sounds fine.
It's a lot.
Okay.
And I would hate to have to.
That was kind of where we wanted feedback, so we put that just kind of, we thought it was good, and we wanted to get this group's feedback before we move forward with that.
I think those of us that are using Crossroads to have to add another layer of surveys, manual surveys, would not be beneficial to, us.
Okay. So maybe this is one we can take back as an ACH, because it sounds like we're hearing the 25 is too high. And then we also have surveys that are 6 per quarter per provider that are providing statistically significant data for you to move forward from surveys. That's what I'm hearing. Okay. Okay. All right, shared decision-making, question 1. Oh.
That depends on what you're looking at as statistical significance. It's statistical significance for the site, not necessarily for the provider. So if you had
good point.
6 going out for each provider, it all depends on what you're looking at, what you want to look at.
Okay.
You want to look at the response for the provider, or do you want to look at the response for the site? So if the site, then you do that. If it's the provider,
Okay. Good point. I feel like we can talk about that one, and we'll definitely be sending out a follow-up email in the next couple of days to get more thoughts. Okay. 4A2, shared decision-making. Number 1, identify at least 2 health conditions, decisions, or tests of focus for which your practice is implementing shared decision-making. So just to kind of give a quick recap, shared decision-making means rather than me going into the doctor and you telling me what meds I'm on, I would say, hey, I'm diabetic, but I really don't want to gain weight from my meds. So you would try to get my feedback and say, okay, we're going to give you this one. This one might affect your sleep, or this one might affect your appetite, things like that. So what we're asking for this is for at least 10% of eligible population to receive that decision aid. So right now, our organizations are reporting how many patients with their specified condition, so diabetics with A1C over 9, that they have, and then how many got a shared decision aid. But yet again, there's no threshold there. There's no minimum requirement. So we would like to add 10%. So if you had 100 diabetics, A1C over 9, 10% got that shared decision-making experience. Thoughts? Seeing none. All right. 4A2, question 3. For each of priority selected, indicate counts or rates of eligible patients who received a decision aid. For each of the priority areas select, sorry, got a phone ring. Sorry. So for this one, yet again, shared decision aids. Oh wait, this might be duplicated. Just kidding. Okay, can fix that one pretty easily, just delete one. So this is where we might have an opportunity for discussion. So with shared decision aids, do we think 10% or 25%? Because clearly we thought both in our internal meeting Friday afternoon.
Different questions.
I think they're the same question. Yeah, they're the same question. So I think we need to talk about what is the right percentage based on kind of this group's feedback, 10% or 25%.
Can you look at what's being reported now, kind of what the percentage is, and if it's closer to being achievable to reach the but if most people are at like 18 or higher, then we go for the 25%.
That's a good idea. And we'll have that data to be able to look at once we talk to our CSI folks a little bit more later this week. So that's a great idea. So this could be another one that we follow up on an email with just kind of what the average is right now as of quarter 3. Okay. All right, so next one is milestone 5, question 1. Basically, this question says that you're attesting to having an internal QI team that meets no less frequently than monthly. What we found is that for some of our organizations, not all, when we have their QI team, it's their QI team meeting is also their practice transformation meeting as well, where we go over milestones and talk about stuff like that for some, not all organizations. And so what we would like to add is a monthly minimum of QI meetings to happen without me and Martine. So this is where you're kind of looking at that sustainability approach, like teach a man to fish kind of thing, like let's make sure you're having those meetings that aren't just practice transformation geared, but are also just your quality improvement for your site, for your organization. For most of our organizations, this should not be a problem. We just do have a few that are, when we come, that's when they meet. So, thoughts? Okay, head nods. Awesome. Milestone 5A2, question 2. Your practice should review all CQMs, which are clinical quality metrics, for your entire practice site on a regular basis. Identify how often your practice is reviewing all CPC CQMs for the practice site. So we're going to go ahead and strike through CPC because we took that out in our update. And so what we're asking for is either weekly or monthly review of the clinical quality metrics. Currently, they have 2 additional options to that, which is to select quarterly or in planning. From our perspective, if you're looking at quality metrics, you should be looking at them monthly. You kind of miss the opportunity to implement quality improvement if you're just looking at them on a quarterly basis. So we thought we should remove quarterly and also in planning because it is year 2. Thoughts, feedback? Head nods, awesome. All right, 5A2, question 4. Your practice should regularly create individual practitioner or care team CQM reports. And we would like to add a mandatory upload of report examples. So we thought that this was good to have just a little upload button right there on the screen. It doesn't have to be in a specific format. You would just upload those provider level or care team level reports to us. And this is just kind of our like due diligence saying, okay, we've talked about having this at the provider level. Can you show us these reports? Silence and head nods, I like it. All right, 5A3, which is your practice transformation implementation work plan, question 1. This is our gimme question because me and Martine do this one, but it's actively engaged with your practice transformation navigator to implement and update the PTIW document throughout the demonstration. Literally, me and Martine do this. So we want to add a minimum monthly meeting with the practice transformation navigator. This normally happens anyway because we harass our site to meet with us. So yeah, we thought this wasn't a big ask. Head nods.
It's really over the line.
It's just too much. How dare we ask them to meet with us?
Draw.
Okay, care coordination across the medical neighborhood. So we're just doing some reformatting of these questions. So we said, please attest that your practice uses one of the following: collective medical and or direct secure messaging. So we want the use of collective medical to be mandatory in 2020. We have a bunch of eager organizations. We are in constant contact with collective medical staff. They have had some turnover internally, so it's been difficult to ping a person down, but we think we have our person. Her name is also Jenna, so it's really weird to send her emails. But we would like to have the use of collective medical be mandatory in 2020 with the still same understanding of MCO sponsorship of that platform? Yes, Becky is firmly nodding yes. Okay, so milestone 6A1 question 3, this will be a new question, which is why that column is blank. But please attest that your practice is using One Health Port. We would like to have this mandatory by Q2, and I put in red that this is a new question that will be added in 2020. We just would like our sites to be using One Health Port. Most of them are, but we just thought that that should be a mandatory thing so we can use some of the data systems that our state already has.
And the first year is a free subscription.
Yes, the first year is free subscription, and I believe that's for view-only subscription. But we also give out dollars sometimes, so, you know, pay for it. Okay. Okay. Seeing no comments. Last page. We did it, guys. Milestone 6A1, question 4. Oh, gosh, I shouldn't have spoke so soon. So this one is, for those of you who are familiar, I'm not going to read this word for word. It's milestone 6, which is care coordination across the medical neighborhood. We give sites 3 options. First option, follow-up contact within 1 week of ED discharge. Second option is contact 75% of patients who are hospitalized within 72 hours. And the third is enact care compacts and collaborative agreements with at least 2 groups of high-volume specialists. We would like to propose that those are no longer options, that all 3 are required in year 2. And so we also would like to propose adding a element for uploading. So yet again, we make collective medical mandatory, as we just all silently nodded to that we thought it was a good idea. We would like to have them upload those collective medical reports to us, excluding any PHI, any patient information. So I've seen those collective medical reports. They just pull them up. You can export them in Excel, hide a column, save it, slap it in an upload file. So that's what we would like to have for those. The first 2 options is to require an upload. And in option A, we would like to have a minimum % of patients be contacted after ED discharge. But if you'll notice, there is no percentage there because we wanted this group's opinion on what the percentage should be.
100%.
I've heard 100% thrown at the table, so.
Becky.
Well, I'm still trying to wrap my brain around the options here. So the report that you're asking for is basically a census without names?
Yep.
And it's going to be, you're asking for that, why?
Just so we can see like that patient data, not patient data, but the, gosh, that completely contradicts what I just said. Sorry guys, long talk. Just so we can see kind of trends for our region, like how many patients are coming, and we know they report on it, but we're nerds. We just want to see the data.
You want to prove that they know how to do it?
Yeah, basically, that you're looking at it.
And also we can also see at the provider, not only the organization, but the provider level data, who's producing, who's not producing. If there's an issue within the organization just on a lower level of provider that is not following up, maybe it's a team-based approach within the organization that's not working for one team as opposed to the overall organization.
So I have a question about option A.
Okay.
From a hospital perspective, not a clinic perspective, are we talking about contacts within a week of ED for what percentage of patients that come into the hospital?
That's a great question.
Or are we not talking about the hospital at all? Are we only talking about the clinics? So if Dr. Taylor has, 5 patients that come into ED, he would be following up, or his team would be following up on those 5 patients. Do you see that?
Yeah, I see exactly what you're asking. I think we had this discussion on Friday when we were talking about this one, and the thought was kind of what we're doing for Lourdes already, like that hospital. For those patients that go to Lourdes, that are Lourdes patients, that wouldn't be the ownership of the hospital. It would be the primary care provider, so the patient wouldn't get 2 calls. Okay. But Sam, am I missing anything from, or Martine, anything from that thought that we had?
No, the health, so what we were thinking is the hospital, with that collaboration agreement with their own healthcare systems or their own clinics within that collaboration, they would be sharing that data to make sure that those patients are being followed up on.
So what about Lord's Clinic patients who go to Catholic, for instance?
So
They
they should be following up on those patients that are going to Catholic. So say, for example, Dr. Taylor is his team or his MA, whoever that he has, pulling that collective medical report, and then they're looking at the data of who visited the ER last night, and then they're following up within that time frame. Then it would be all patients that are associated with him as a primary care that he's uploaded, that he's receiving those data points on. But for the hospital, that's a little bit different. So the hospital, they would have a collaboration agreements with, of course, with their family medicine, their internal family medicine, if they had their own healthcare system. But for those organizations, those hospitals that, and I don't think we have any that are not associated with their own primary care, that they would have that collaborative agreement that they would work together collectively to make sure that those patients are followed up on.
So you're saying that, just for example, Lord's Clinic and Catholic Hospital would have a collaborative agreement on who's going to do what? I don't know about that.
So would the hospital still be required to follow up on those patients that aren't going to their clinic?
The question, Sam, was would the hospitals be required to follow up on patients that aren't going to their clinics?
No,
So
the hospitals would not know that those patients are not going to their clinic. The clinic is, the primary care is the one that would be more associated. They would just make sure that they have that collaborative agreement with their hospital. The hospital would be making sure that they're sharing that data, that they're following up on the patients, and there's collaborative effort to make sure that within their healthcare systems that they're followed up on. Now, on the primary care side, it's a little bit more extravagant. They're going to make sure that they're following up on all of their patients that are going to, regardless whether it's their internal healthcare system. So an example would be Catholic. They were following up on those patients within that time frame, 72 hours after the ER.
So I think I have a summary because I feel like I see some furrowed brows in the room. So if you're a hospital, your Lords, you have also your family practice and your IM. The hospital is not required to do the follow-up. They're required to push that follow-up to the primary care provider. Is that what I'm hearing?
Yes.
But for the patients that are, gosh, it gets specifics, it gets confusing. So for the patients that aren't, like they go to Cadillac for the ED, but they're a Lord's patient, Lords would still own that patient. Cadillac Hospital would not be responsible for the follow-up. Lord's.
Correct. Yes,
So
correct.
Sam, this is Barb. I thought the workbook said that for patients that, Dr. Taylor's patients that end up at Cadillac ED, I thought the workbook said we had to follow up, primary care has to follow up on patients from the, I think it's called the target.
You're right.
hospital.
You're right.
And so each organization has a target hospital, so Lourdes would have Lourdes Clinic would have Lourdes target hospital. I would assume Cadillac clinics have Cadillac the target hospital. So we would.
That's correct.
Primary care
That's
clinic.
that's what I was talking about when the collaborative agreement for the target.
I do this all day, every day, and I have problems. So patients that go to Lord's Clinic do not just Lord's.
Right.
And where you're going to find gaps is when your Lord's patients go to across community. Exactly. That's where things are going to fall through the cracks.
Also, some patients go to the emergency department and don't have primary care, period.
Right.
Many. Yeah. So I don't know how I don't think the use case meets your data requirement.
And historically, it's those patients that don't have primary care that we're really trying to do these follow-ups on because we could set up an appointment for them, but we'll call them and say, did you go? Did you get an appointment, or can we help you get an appointment, or how are things going? Because you don't want them to be just out there. Yeah.
There might be something for us to take back because don't know why, you said it and then it thought of an idea of changing maybe some of the options. And Sam, you can completely shut this down or whatever, but maybe for hospitals, rather than ED follow-up, it could be % of patients that come to the ED with no PCP and how you help that patient.
Yeah, I like that. I like that identification, especially if they're making sure that they're doing the benefits verification at the time, and then they're associating whether they have a primary care and they're already affiliated with that primary care. Yeah, I like that a lot.
So that way we would.
You're not going to get that information out of Eddie.
You can get out of provider one though if they have primary.
Yeah, but that's a lot of manual work to cross-reference to systems.
But wouldn't the sites, I know for Lord, we have that, a report. They just made it internally. And we pulled that up. I remember sitting in the room, we were like, this many people have no PCP or blank, so they have it internally. So maybe this measure, if we went to having the hospitals focus on percent of patients that come to the ED with no PCP, there wouldn't be a collective medical requirement. It could just be a finding that data in whatever way you can through your own internal check-ins, and that could lend to process improvement there.
Yeah, that's through Provider One. And Sacred Heart's doing the same thing right now. They just started a program at Providence Sacred Heart around the state initiative. And it's not, but I'm just saying that it's not, it would be related to collective. Take the information out of collective. You have to get it out of Provider One. Or you could get your census, but you have to cross-reference Provider One to see how many actually. It's a lot of manual work.
Right, every Apple Health patient is required to be paneled to a provider or provider organization. So.
And we're back to the panel question.
Yeah, but
are they really responsible for the ones on their panel, their roster?
Well,
the ones that walk through their door.
Then that gets to be a real big task, but at least they can verify through Provider One who they were assigned to by the MCO.
So I need some help landing this plane.
when you're talking about the highest utilizers and the people who are like on the edge of loss to care, those are the people who come into ED.
Mm-hmm.
So because you've got this tag, an ED visit, available or not, you're talking about a lot of energy trying to document follow-up.
Okay, so tell me how you think about it. I think it's appropriate to leave the ED follow-up at the primary care level, but I think we kind of have a good idea with the hospitals shifting it from ED follow-up to do you have a PCP at the hospital level? What are the thoughts on that?
I think that makes perfect sense.
Okay.
Because, like we talked about, highest risk patients are usually those without a primary that end up in the ED and end up in the ED again and again and again because they don't have a primary or they have not connected to a primary.
Okay.
So to me, that should be a focus in the ED, trying to connect that patient to a primary.
Okay.
I guess my biggest concern
I'm looking at everything.
is in our community, I mean, we can assign people to providers. That doesn't mean the provider has capacity to get them in.
That's a good point.
Work with them.
Or that the MCO is on board with that.
We have one unaffiliated practice in town that has switched from 7-provider traditional primary care practice to a 4-provider direct primary care model. They have, we believe, on the order of 12,000 charts and are constricting their capacity to 2,400 patients, which means they're displacing something on the order of 8,000 or 9,000 patients into the community. So every system in the county is impacted right now.
Also with Becky Betts at St. Mary's Medical Center, and she was talking about their top overutilizes, 388 people in that federal definition, that C5U definition. 64% of them had substance use disorder diagnoses, 89% of them behavioral health diagnoses, versus 8%. I mean, you can tell hospitals to assign them to a PCP,
right?
But you can't, make that horse drink water, and
right.
You can't assume that PCP is going to be the best person to care for that overutilized.
That's true.
So I think I feel like I know what you're trying to get at with the requirement here for 2020, and I want to help you get there, but I don't know that this is going to be the practical way to do it.
And that's fine, like, that's why we're here. Like, let's talk about it, let's flesh it out, like, what, should it be a referral to behavioral health if they have come in for a behavioral health something in the ED, like, what?
I mean, the discharge planner is gonna have to do something with them anyway, right?
But where lies the responsibility then of the MCO? So if this patient is supposed to be rostered and the MCO isn't providing that capacity because that's one of their conditions, right? Is that how do we also circle back and say, okay, MCO, what are you guys doing? Because they are the ones that are getting paid to do the care management. If this patient is that high risk, they should be in a health home. Why aren't they in a health home? What is the MCO doing? So I think that this deserves more conversation. And it's not just about primary care. I really think now we're delving into an area where the ACHs are all coming together around care coordination in health homes and health home referrals. So we'll continue this, I think.
So, to point out here, it doesn't specific, unless I've missed something, Jenna, it doesn't specifically.
Sorry.
The requirement doesn't specifically state that you have to focus on the high utilizing patients. It just says a percentage of overall patients. And so, not to shirk responsibility, if the hospital or the primary care decided to work with somebody who had less than the highest amount, they can still do that.
Right.
So, and I know that the data that you're talking about, I just saw something similar recently in terms of high utilizers and the substance use and behavioral health issues. We're using other methods to address that too.
Work. So we can add this.
Out of the tree, breaking
Hey,
his leg.
this is Marissa. Sorry, this is Marissa from Coordinated Care. I just wanted to circle back to Carol's point about the responsibilities of the MCO and case management work that we do for our members. We're seeing the same provider capacity issues that was previously mentioned by someone else. I don't know everyone's voices on the phone, but there's only so much we can do as a state right now. And honestly, we're seeing those capacity issues everywhere across just about every system of care and that you can think of, that makes it a challenge to get our members the services and treatment that they need. The wait lines are really awful.
Excuse me. Thank you.
Thanks, Marissa.
Thank you.
But as an MCO, when you assign a member to a primary care provider, you're assuring that that primary care provider has capacity to accommodate that member, correct?
That's what I thought.
I didn't hear the comment. The speaker's too far away from the mic.
So I think, Marissa, the comment that Becky Gross made was that once a patient is rostered to a provider by an MCO, isn't it the MCO's responsibility to make sure that that patient gets in with the provider, or somehow that there's capacity, right?
So to a certain extent, I'd say in an ideal world, all patients would be compliant with the care that we want them to receive in a preventive manner. I think we all know in the room that patients aren't always compliant and always receiving the care. So we have challenges with making sure that our members actually trust us to pick up the phone when we call them or send them, things in the mail, or having reliable, mailing addresses in the first place. There's all sorts of communication challenges with that. So there's a lot to work through. That's not to say that we're not responsible for our members. We absolutely are. We just don't live in a perfect world.
Yeah, so I understand that. My question isn't about the patient's compliance. My question is, when a member becomes a member within an MCO, you assign a primary care provider automatically. And when that assignment is made, are you, as an MCO, are you assuring that when you assign to primary care clinic A, that primary care clinic A can accommodate that member, that they have capacity? And therefore, that's the roster, they're put on that clinic's roster, correct?
Did you hear that?
was
Marissa.
really hard to hear. Hi, this is Amelia from Coordinated Care. To the best of my knowledge, yes, we are saying that they do have capacity, but that doesn't mean that the clinic hasn't notified us that they don't have capacity or if something did get lost. So as far as we know, if we assign a member to a clinic, we do believe that they have capacity and they haven't notified us otherwise.
Okay, so it sounds like for this milestone 6 question, we as an ACH need to go back and talk about it a little more, flesh it out, send the email. There might be an opportunity, what it sounds like to me, is to reach out to our MCO friends and talk about what this rostering process looks like and how that information gets to the clinics. And then we could circle back with our clinics that we have a relationship with and say, what are you doing with this? Are you getting it? Are you looking at it? All that good stuff.
One last milestone.
All right, last one, guys. 7A1, participation in learning collaboratives. Right now, they're only required to attend 4 learning collaboratives and 4 leadership councils a year. We hold 12 of each of those, so 24 in total. And so what we're proposing is that there would be mandatory learning collaboratives on billing, shared care plans, shared decision-making, and self-management tools. So rather than getting to choose whichever 4, we would like to propose that those 4 have mandatory attendance. And we're also talking internally about ratcheting back the amount of learning collaboratives that we put on as we bring on more cohorts. So everybody seems to like that one. Okay, it's a good ending. So we got some follow-up to do. We'll be sending out some emails. MCO, please look out for our emails. We can talk about what the rostering process looks like and all that good stuff.
And when will we get the final changes?
That's a great question. I would venture to say in the next 2 weeks. Well, we have to get together. Yeah,
sometime.
Yeah.
Oh, yeah.
For the end of the year.
Oh, yes.
Before everybody takes off, I wanted to just really quickly cover, we won't go into this, the last item on the agenda is around dashboard that we're working with PSI to put together. This will be a provider-facing report that will look at about a dozen measures. The document that was in your packet includes our first one of those measures. So if you would please read through those and see if those make sense to you as being high-level measures or metrics. If there are additional metrics that you think that we should be including that come out of the portal or come from somewhere else that we would want to put into the this dashboard, we can talk about that perhaps at the next meeting. So please read through that document, and if you would please come back with some feedback.
Becky, did you want to talk about, real briefly, about the revenue sharing model?
Yeah, back to Barb's question.
Here, come,
Oh, she's going down there.
So back to Barb's question, this all will be finalized this year because this will be changed to the current contract with cohort 1 providers. That will start in January, so these the new contract will be coming out then.
Yes. Yeah. Okay, that's it. Thank you, everybody, for your participation.
Thank you.
Okay.